My wife currently has strep and started a Z-Pack yesterday. So bless her heart. I started a Z-Pack this morning. I just woke up with some throat symptoms. Just
Time.
So, anyways, so anybody have any questions on the homework?
Yeah, on the exam.
What was the,
When,
that one?
yeah, that one.
So one that came up, I had this in my place, was you have a concentration. What was the concentration?
It's like 125 milligrams per teaspoon, and 6,000 grams.
No,
and
6 grams.
Yeah, 6 grams, and like 21.8 mLs or something like that. And there was a 21.8 mLs.
Okay. I don't know if that was the exact concentration, but I do remember 6 grams of powder and a volume of 21.8. So we'll do this real quick. So anybody have an idea how to do this?
You gotta do the teaspoons to ml, so
Right,
it'd be
so-
125 milligrams per 5 mLs.
We can just do that. We don't need to do any math for that. So
And then
we need to convert it to mLs.
6 grams is 60 ml, or 360 ml.
You gotta do 6 grams to milligrams in order to be able to work that out.
Okay, so we're doing dimensional analysis.
Oh, those
So
are
we've
grams.
converted from grams to milligrams,
So that's
What's next?
6,000 milligrams.
and then we have our conversion factor.
30,000.
Divided by 125.
One more.
What's that?
240.
You keep putting an N after your grams.
Yeah, that's why I thought it was grams because you had an M there.
Because that's a bad habit. Thank you.
And then
Remember, I've been doing math and meds for over 8 years,
You don't do it the same.
and I have some bad habits that have come about. Okay, so that's 240 mLs, which would mean 6 grams in 240 mLs, correct? Do I add 240 mLs?
no,
No, because I have what?
21.8.
21.8, so I need to do 240 minus 21.8.
218.2.
So it's 218.2. So that's how many mLs I was supposed to add. Okay. That's using dimensional analysis. Okay. Is there any other questions? Who here has done it actually?
And then there's like a milligrams per kilogram per day one. I can't remember exactly how it was.
What else?
What was the answer?
I've just been working on them in the book, so
Uh-huh.
I can practice.
Yeah,
Um,
that's fine.
so like on number 75 on page 435, chapter 19.
75. For what?
435. So it's not so much that I need help, I'm just wondering, as far as figuring out the problem, but, so, they have it there, on this one in ounces, and then in the answers, it shows to do it, shows the two different ways, for ounces and milliliters, what's the smarter way to do it, or the better way to do it?
What is the answer asking for? Ounces or mLs?
I think it shows you both ways, so it's just asking you to compare it on any.
3/4 strength. And 3/4 strength of 16 ounces
75.
total. Okay. So. Total, right? Let's see, 458. You see exactly what it's asking for.
Well, you're figuring out how much water you're in, I mean, milliliters in water, or ounces actually, they have it in milliliters and in ounces, that's my question is it
Do they want to?
better, it doesn't really come right out this way,
Well,
then it shows you both ways.
we should have it in mLs, but you can convert that after the fact. Does that make sense? So you can just do it with 16 ounces, because 16 and 4.
It's just 12.
Yeah, it's just 12.
Yeah, which is 12 if you did the math. Cross multiplication of it, so 12 ounces, 16 ounces. So, if I have 3/4 strength,
Well, it's 12 ounces.
how many
is
ounces of
sure.
water am I going to have?
4.
And how do we figure that out?
Because 12 ounces is the actual insured, because it's 3/4. And 16 is total.
Right? So, if I have a total 16, minus 16 minus 12 is 4 ounces of water. And then you can do
4 times 3.
which is 240. Okay, so that's 240 mLs of water.
It's actually 120.
120.
Yeah, see, if you were watching, I was just making sure that you was doing that. So 4 times 30. Good catch, you know? You guys are passing all my tests today. See, I'm just testing you guys, make sure you're watching and.
Actually doing the homework.
Yeah, exactly, no, I just wanna make sure you know your times tables,
We appreciate it.
so. What else? Good questions.
Let's look at the first one. That one was that you helped.
On 456, page 456, will you do number 37?
37 on which page?
456.
It's the same thing.
And number what, 37?
Mhm.
6 ounces.
2/3 strength.
2/3 strength of 6 ounces of isomil.
4.
So if we did the cross multiply and divide, that would equal 4 ounces, right? Okay, so we're trying to figure out how much water to add or how much isomil to add.
Prepare.
Okay, so this is how we would do it then. So we know that we have 4 ounces. When it's 2/3 strength, this is 2/3, meaning the top is going to be the actual concentrate. The bottom is the total. So we know that we need to have 4 ounces of isomil. And then 6 minus 4, 2 ounces. So 2 ounces of water. That way we have the 6 parts combined for that total on the bottom. 4 parts isomil, 2 parts water. Right? So we could do it to mLs if we wanted to. So 4 times 30 is
120.
and 2 times 30 is. Okay, so that's a way to do that. We had to prepare it. What if we needed to do it for, it says we're going to do a 24-hour solution, what would we do?
How many times?
And
a day
it's,
was
and
it?
it's ordered 4 hours.
3-4 hours, so
Every
6 of
4
them.
hours.
So then you could just times these by 6, right?
Yeah.
And that would give you your 24-hour totals
Right.
to mix. So you can mix your total amount, right?
Mhm.
So 720 and 360.
Yeah, if you did the math. Any other questions? So, looking at the syllabus, I made a little mistake. I made it so we missed a week, or what's the word? I missed a week on syllabus, so we were a week ahead in class. Does that make sense?
That's fine.
So I redid the syllabus. Here's the updated syllabus. Just the what page? The second page of it. Kristen, is it official? Did you tie the knot yet? OMG, it happened. So where'd you go on your honeymoon? Did you go on honeymoon yet? Is that what
Yeah.
spring break was?
Yeah,
And where'd you go?
the Dominican Republic.
Wow.
Yeah, it was awesome.
Yeah. Looks like you got a little tan.
Yeah.
So we're supposed to have a test today, is that it?
No, if you remember when I said at the beginning of the year, since I'm doing this online, if I was doing this as an in-class, we would have a test, okay? But remember, since I now have this all on web study for you guys, including the web study class, these dates are just guidelines to tell you when you should be completing your test by. Last semester, the way I did it is before I started class, I would close the previous week's tests. So they knew that they had to have it done before they went to class that day, because I would close it at 9 o'clock. so when they're coming across the new material open, the old material will close. But this semester, I'm trying that whole two separate dates where everything closes, instead of doing it every time. That way you guys have more time in the modules. So, something I'm trying. So that's why, just follow these, kind of give you a guideline on when you should be taking your tests. But,
By
yes.
the way,
Yes.
that one module said, sign up for me or something like that, after you watched the tutorial. And we didn't have to do that to submit that we did it, correct?
The tutorial? What do you mean?
It said something like, it's in 19,
I'm looking right now.
it's the second one, I think. If we're not graded on whether we opened and read and watched the module, then we wouldn't have to join or whatever it was it said. If you wanted us to submit it to an instructor, you had to sign up or something.
What are you talking about? In 19, I have the PowerPoint, the in-class lecture, the glucose and insulin video, and then the two videos that Chalet recorded showing how to do those things. I don't have anything else. I have a 19 and 20
And
assignment.
it's gotta be the glucose one.
No, that's just for a video, just to look at and watch.
Right, okay, because it said at the end of it, sign up now or something like that.
Oh, because it's an
Submit.
external website. So when you click on ones that go to YouTube or whatever, then that you're going out of web study. So unless I tell you to do something specific on that page, it's just a link to a good video.
Okay,
Okay, so there's nothing to do or submit on that
okay,
because that is a
just a tutorial.
tutorial. All right. So, where were we at? We have today's chapter 21. Any other questions on 19 and 20? Anyone? Make sure if you have any questions, you come see me or you go to our specific math tutors, okay? Especially now. If you email me, I will email you back how to do a problem or a question, but just remember it will be in dimensional analysis, okay? I don't do the formula method that is also in the book. I use dimensional analysis because that can be applied to all math for meds, whether it be a simple Tylenol dose or whether it be a advanced ICU calculation that we'll be doing here coming up. Okay.
What's
Yes.
the best email to use? Your website?
So I log on web study every day.
Yeah,
If I'm in my office, I check my web study email a lot.
okay.
But if I'm not in my office, I will check it. So I get every night, I get an email from website that says, hey, this is new activity for the day. You've got this many assignments that have been submitted, and you have this many emails in your folder. And so if I see it on that time when I'm at home, I'll get on and I'll check it and answer emails. Otherwise, I sit, when I'm in my office, I have web study open and I'm answering as they come in. So the best one, if you need immediate results, an immediate question, I prefer you use web study because I'll answer it while I'm in there in web study looking at it, because I get questions all the time like, why I did this assignment and why is it not showing up? Well, then if I'm not at home, then I have to go to a computer, log in, see what's going on. But So that's why I prefer to do it at work, because I'm already in website, so I can just click really
Yeah,
quick.
that works, that's great.
But if it's emergency, like, hey, I have, this is closing at midnight, I've been trying all day, I'm having technical issues, will you help me out? Then send it to my work email, because that goes to my phone. And then I'll stop what I'm doing and I'll go try to track down the video and see what, the computer and see what's going on. Which happens every blue moon. So I try to help you guys out. So I prefer web study first, and then email me on the, and if you do both, if I haven't responded quick enough for you, then make sure you let me know, hey, I emailed you in web study, but I need to get this in by midnight or something. Let me know. Okay. I got a lot of those on March 13th at 11 p.m. OMG, it's assignment 1 through 5 is not opening. Holy hell, you have a long way to go. So, let's see if we can get this right. So we're going to do, I opened up the module, and I see I lined out your assignments in your web study based off of this syllabus. So this module barely opened up this morning, so I'll get started on that. We have a PowerPoint, and then we'll do as many questions as you want to do from the book. Check the filter, it says. Alright, let's try it. So for those that are going into nursing school, this is where we get to the bread and butter of it all. This is the stuff that you learn to be a nurse for, and that's IV stuff. So this is chapter 21, 22, IV solutions and equipment, IV calculations. So if a client receives an IV infusion too rapidly and is not monitored closely, reactions can vary from mild to severe. Severe, by the way, if you're wondering, is death.
Yeah.
We have to make sure that we understand how to administer IV fluids, how fast they should be going. That's your responsibility as nursing staff, because the doctor can write an order, but if you don't program the pump correctly, or watch the right drip factor correctly, you can overload your patient. Does anybody have any ideas what I mean by overload, or what I'm talking about when it comes to IV rates? So if you gave me a liter in 30 minutes, I would probably do just fine with it, because I have sufficient kidney function. I would start peeing like a racehorse and get rid of it, right? But if I did that to a 95-year-old lady with CHF, if I gave her a liter, her heart couldn't keep up and her kidneys aren't going to keep up. So she has to put that fluid. The body's response is to put fluid somewhere, okay? And what usually happens to 95-year-old ladies who have CHF, when we give them a liter of fluid like that, they put it in their lungs. Do you see a problem with putting it in your lungs or causing pulmonary edema? What's going to happen if I cause pulmonary edema? Then I'm not going to oxygenate appropriately, right?
You're essentially going to drown.
They drown in their own lungs, and we drown them from the inside out, and then they have a hard time breathing, and then sometimes it can lead to expiration, right? Dying. So that's why IV rates are very important. What about for ICU calculations? If I have a medication mixed in here, I'm giving a set dose.
You could overdose the crap.
So I can overdose a patient based on my IV rate.
Or you could underdose.
Or underdose them depending on So for those continuous drips, so just making sure you understand. What if I have potassium? And I'm supposed to,
Oh, you could kill them.
you could kill them. Potassium is what they use to kill people, right? That's how they do lethal injection. Is potassium. It stops the heart. So if I give that, I do my math wrong, and I give potassium at the wrong rate. It's going to hurt like hell for the patient because it burns as it go in. But I would have to push a large amount pretty quickly to kill a patient, but I could cause some cardiac arrhythmias, okay, that could lead to patient demise or cause some other problems. So, very important to understand your IV rates. So we have IV infusion set. This is where you're using like a big bag. We can hang smaller bags also depending on what we are running and what our goal is. But most of the time we use a big liter bag. Sometimes there's potassium chloride added to that. But usually when we have something like this, it's in a larger volume, and it's about 1,000 mLs. Here's just some IV tubing that you guys can take a look at. This is from, we don't use these pumps at Mount Graham anymore, but we do have, this is the pump set that they use at the Globe Hospital. So we have the drip chamber, as you can see there. That tells us we fill it about halfway, and then we can see the dripping. So that means when we see a drip, that means that we are flowing, right? As that goes down, we have an extra clamp here just in case. When we're priming, we can stop it here and fill up this before we let it go out. Because if I don't fill this first, when I'm priming, I'll just get a nice set of bubbles that stay in my line that are hard to get out. So if I clamp this and fill up my chamber, then when I open this, then I have a nice flow of good solid whatever infusion I need to do. Here is this is the pump chamber. When I pass it around, you'll feel that on the back it's rubbery, okay? This clips into the pump, and there's a little fingers that come up and they run down the back of this in a wave-like motion, and that's what creates the force of pushing it down. So if I push down here, it's going to create suction and pull down here. So when you put it in a pump and you put it at 9999, you'll see it go drip, 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 because that is the fingers going down the back and then resetting, pumping, okay? So I'll pass this around. And then this is the end. It has, obviously these are the lure locks, the needleless access system, and then this is what attaches to the patient's lure lock on their IV set that's inserted. So I'll pass that around, you can take a look. This is what a liter bag looks like. This one actually is D2.5, half normal saline, okay? And some of the problems we'll go over on the board is just a reminder how to figure out how much dextrose is in the solution when it comes to grams, and how many
D50 is 12 and a half.
depending on. So we'll do it by volume, and we'll learn how to do that. So that's just what a liter bag looks like. We have IV piggybacks. We use IV piggybacks when we are doing antibiotics and those kinds of things. Why don't I just prime the whole line with why don't I just prime the whole line, a new line, and give it over the infusion set?
Because it could be too concentrated if you were just to get it straight.
Not so much too concentrated, because once it gets to their vein, using even the piggyback, it doesn't dilute it. The main point of using a piggyback is because I might give something in small or large or small volumes. Okay, so let's say I have a 50 ml bag. How many cc's does it take to prime an infusion set? A whole big infusion set? Almost 20. So if I use a 50 cc bag with my medication in it, let's say I'm giving an IV piggyback of ceftriaxone, which is Rocephin, and that's usually 1 gram in 50 mLs. So I prime my bag. How much medication is left in my bag? 30, right? 30 mLs. So then I start my infusion set, and I run it on the pump for 50 mLs. Well, it's going to stop when air hits the sensor. Okay, so how much, my bag is now dry, how much mLs is in my tubing? The 20, the part I primed it with. So has the patient been able to get all the medication?
No.
No. So that's the importance of using an IV piggyback is, I can hang it here. This is the primary bag, hangs lower than the secondary bag. That way, gravity actually selects which one's flowing. Because if I have my secondary bag above my primary bag, it's no matter what, because that's what physics is and gravity does, secondary bag is going to burn first. Okay, and so I can set my mLs for 50 mLs, prime my short, low volume piggyback line, push start, and it's going to infuse from here. And then once it gets down, when the level gets down to the same level as the drip chamber or the level of fluid in the bag, it's going to stop. And then this will automatically, because of physics and gravity, take over dripping. And it will flush the rest of the line to make sure that they get all of the medication. Okay, so that's the importance of using a piggyback. So this is just kind of a smaller bag. This is a 250 cc bag or 250 ml bag. Bad habit, like I said, 8 years of being a nurse before teaching this class. But 250 ml bag of D5. Okay, there's one called Advantage System.
D5W. Sorry.
The Advantage System makes it so that I can mix medications in a sterile environment without ever having to open anything or touch anything. So what you do is you have your Advantage vial that has a set loaded amount of powder needed to reach the proper concentration. And then you have an Advantage bag. On the bottom of the Advantage bag is a big rubber stopper. So you pull the rubber stopper off of the Advantage bag, you pull the cap off of the Advantage vial, and you screw them together. There's actually threads on the bag, and it clicks and locks. So that way it can't be unopened, okay? Once it's set, it's clicked and locked, okay? Then, like it shows there on C, right here on the bag, there's a little rubber stopper on the bag that when I pull that off, it opens up the vial and the contents just dump in there. So I'm not touching that powder, I'm not able to contaminate my solution. And I shake up my bag, and now I have an IV piggyback, and on the bottom of the vial there's a little plastic hook that pops up so you can hang it up. So that's the Advantage vial system, something you guys will see later in your careers. I'm just kind of showing you guys some of the stuff that we use at the bedside. Same idea as this Mini Bag Plus, but what's cool about the Mini Bag Plus is it doesn't have to be an Advantage vial bag, or excuse me, it has to be a mini bag, but it doesn't have to be an Advantage vial. I don't have to have a fancy rip-off top and the fancy stopper that pops open in the bag. You can use a regular bag because this neck size is universal, okay? And so what I can do is I can pop off my plastic cap, clean it with alcohol, and then pop it in there. And on there's a spike. So I ram it on there, and then there's the spike. It spikes my solution, okay? And then I break it right here. There's a little break point. When I break it like that, then the fluid can go into the vial. I can shake up my vial, flip it upside down, and get the fluid to go back in. And now I've mixed my medication, and I can. So these are two ways that I can mix IV piggybacks at the bedside without contamination. It keeps it separate, okay? So I never have to touch any fluids or extract anything. It's all within the closed system. This is a volume control set. When would I want to use a volume control set? Anybody know? Anybody that I want to make sure that I don't overload a patient. Primarily we use these, and it's based on hospital policy, but primarily we use these in the hospital setting for all pediatric patients. Because if I gave a neonate a liter of fluid, which is like 4 times its blood volume in general, I could kill the neonate. I can cause acute CHF and kill the baby. So when we want to watch exactly the amount that goes in, We use this, what we call, it's called a Buretrol or a volume control set. And what you do is, it has a clamp below and a clamp above. So you clamp the clamp below, clamp the clamp above, and spike your solution. And then you can open the clamp above and fill up the exact amount that you want. And this is in milliliter increments. So if I want to give 101 mLs, that is possible. I can give 101 mLs. Okay. So once I'm done, I can squirt and fill my drip chamber up, prime my line, make sure that I have the 101 mLs I wanted, if that's what I wanted, and then I can infuse. And once this gets down, we run it through a pump, and then we'll make sure that the patient doesn't get any air. And then it also, you always run these on a pump, but you can run it to empty, and then you know that you're not going to give too much fluids. Another reason we use this is if we're mixing our own medications for pediatric patients, or if we're doing a lot of medications, we can do it really quick at the bedside for adult patients. So if I know that I need to give, let's say I'm giving Rocephin, and we talked about that 1 gram and 50 mLs. So I can mix my 1 gram up in a syringe and squirt it in here, and then add 50 mLs to this, or add it to the 50 ml line, give a little bit of a shake, and now I have my fluids ready to go in like a IV in a solution. Only thing, if you do mix medications in Buretrol, you have to make sure that after you've cleared the Buretrol, and you set it for the amount that you put in the Buretrol, so that way you don't run it dry. After I've cleared the amount of the Buretrol, then I need to make sure that I add some fluids and follow it up with some more, so that way it pushes the rest of the solution into the patient. Okay? But just some kind of cool things that we use in the hospital setting to make sure that we can be accurate with our administrations to nurses, to patients. This is just how we have some saline lock or hip locks is what they're called. This is the IV that goes into the patient, and then this is a short extension set. We use extension sets because if I had the hip lock right here on the patient, I would be constantly manipulating and moving that IV set around, which is uncomfortable for the patient, and it causes inflammation to the wall of the vein, and can make a IV go bad sooner than later. Okay. So if I put a little IV extension set on it, then I'm moving and manipulating this around, and this actually stays solid and unmoved where I taped it. So that's why it's important to put an extension set. This is an older picture because it has rubber diaphragms where you can, or injector ports. So I could put needles directly into this injector port and give medications via needle, which we do not use anymore. We only use the lure locks that you see on your IV tubing sets. So the same lure lock. These are infusion pumps. This is that one that I handed around. This is the kind of pump that uses it. You can see how that drip chamber that I was showing you guys clicks right into there. This uses a different kind of infusion set, and it has use inside of here. You pop this open and you take this just regular tubing and you circle it through the system, and then it has a little wheel that actually creates that milking action that pulls the mLs out. Okay, you just have to make sure you use the right drip factor set that goes with the pump. Okay, so this is kind of like what Sholo has, unless they've got new ones since. But when I worked in Sholo, this is the kind of pump they had. This is the one that Globe has, and then this is the kind that Mount Graham has. Now, this one's pretty cool. If you notice here, this one says lidocaine on it. This one has a pulse ox on it. This one says it's the medication name. So when you do it, these are actually detachable. Pretty cool. And so all you have is the brain, and you go and as you need pumps, you attach them. You can attach up to 4 to a channel, 4 to a brain. So you just clip them on there, and then you program it at the brain. So I can program a drip. I can just put the drip in there. I can say, hey, I have a patient that's on dopamine that weighs 70 kilos, and I'm going to run it at 5 mics per kilo, and my concentration is 400 milligrams and 250. And it will automatically put the mLs an hour up and the dopamine on the name. So that way I know that I'm infusing a high-risk medication in that channel, not to touch it. Okay. But then if I need to change my dose and I say, oh man, he's crashed, I need to bump him up to 10 real quick. And I go over there, I can just type in 10 mics per kilo pretty quickly per minute, and then it will automatically do my math and change the ml rate. Okay, so that's a nice fail-safe, but what does it require?
Human
A
error.
human to put it in. So if I put the wrong rate in there, or I put the wrong, excuse me, not the wrong rate, but I put the wrong volume, patient weight in there, then all my calculations are off, right? So, what if it was a pediatric patient that weighs 7 kilos and they're septic shock and they need to be on dopamine, and I put them at 70 kilos? Will that change my rate significantly? Yeah, times 10, right? Which could be a bad day for that baby. So there's still some human error that could happen. But so what do we need to do if we have a pump that we're using?
Get it second read by somebody else or third read.
Someone check your pump, and what else should we do? The reason you're in this class. Do the math, right? Don't let it on a
It
machine.
doesn't seem logical for
Yeah,
sure.
especially. I can tell you right now when we hang drips, I can look at a drip and say, hey, that's wrong. Because I know exactly what kind of ml range that you should be looking at. But if I don't hang those drips all the time, let's say I'm an ER nurse that only does it every blue moon. In the ICU, I do it every day, so it's no big deal. But in the ER, they do it only when they have a critical patient come through the door, which could be 2 patients in one day or it could be 2 patients in 1 month, depending on what run you have that day. So if I don't do it all the time, and I don't know that something running at 100 plus mLs an hour for a drip is a bad idea, I could harm the patient. Or I don't know that Levofed is not weight-based for adults. Levofed runs at mics per minute. There's no mics per kilo. But if I program that same mics per minute and the mics per kilo per minute, then whatever the patient's weight is how many times I'm overdosing that patient. So if I'm supposed to run it at 1 mic per minute versus 1 mic per kilo per minute, and I have a 70 kilogram patient, I'm 70 times overdosing that patient on Levofed, which can happen. So that's why it's very important that you look at the order and you do your math to confirm that you're putting it in the pump right. Okay? You and another nurse on high-risk medications will confirm your math, and both will confirm that pump, and then you'll both sign it off on the electronic medical access record or whatever, administration record. Some cool things though. Why would we want a pulse ox on our monitor?
See what their heart rate is.
You can see their heart rate. What if I'm giving them high doses of narcotics?
See if it'll drop their heart rate.
If it's dropping their oxygen saturation, if they're not breathing, then what happens when that oxygen saturation will get low enough, it will alarm if you have a high-risk medication running and tell you like, hey, this is your oxygen saturation, you need to make sure that you're keeping track. Something that is now changed, we don't really use the pulse ox mode, but like at Sierra Vista Hospital, they have end-tidal CO2, because there's a lot of studies showing that my end-tidal CO2 will get to a dangerous level before my oxygen level will. And so that if I can see the trend in my end-tidal CO2 before I actually decrease my oxygen level, then I have better patient outcomes. So we'll put a nasal cannula on the patient that has a special monitoring device on it, and then if I'm getting narcotics through my IV as a drip, as my end-tidal CO2 level goes up, it will alarm and it will even pause the medication. So, pretty cool. All designed to help us not overdose or commit med errors. For a neonate, we talked about that a little bit. The neonate patient, can they handle the same amount of volume as me?
No.
No. Even if I'm giving them antibiotics, I have to be really careful in the amount of antibiotics, of fluid I give them with their antibiotics. For the neonate patient, just using that Buretrol is too much fluids. For a neonate patient, if I'm going to give them a bolus, and it's a tiny baby, 2 saline flushes of 10 cc's a piece could be an IV, a sufficient 20 cc per K bolus, if it's a really tiny preemie or something. So we monitor that very closely. So that's why we have syringe pumps, and this attaches to whether it be 10 cc syringes, 5 cc syringes, 20 cc syringes, and we use micro bore tubing that has the tiniest, it'll take only half a cc, half an ml, excuse me, half an ml to prime the whole set, right? So I can get all the air out, so I know I won't give my patient an air bolus. And then I can put this in the pump, and I can put it in the rate, and I can give them IV fluids and not have to worry about overloading them, and I can actually manage them with a smaller exact volume. So very important. They use these a lot in the obstetrics department. If they have a baby that has some sort of infection or something like that, they will put them on a syringe pump, and they can give them fluids and antibiotics through the syringe pump. So it's pretty cool. Some of the things we do. The ones that we use at the hospital, well, you put the syringe in there, and it has a clamp that goes around the barrel of the syringe, and then it'll say what brand is this, and then when you type in the brand, it has all the measurements of the syringe barrel size. So let's say I have a Terumo 30cc syringe, and I put it in my syringe pump. It will say, what brand is this? Is it Baxter, Terumo, or some other brand? And then you type, I put Terumo, and then that little clasp on it measures it and says, okay, you have a 30cc syringe. And then you say, is this a 30cc syringe? And you hit yes. And it automatically confirms it. So that way, it can use the plunger at the right rate to get the right mLs per hour based on the size of the plunger. Pretty cool.
That's pretty
Wow.
cool.
If I'm using one that's not in its database, then I can select other, and then it will take the measurements while you pull it out and clap it in. You put, this is a 12cc syringe. Then if it knows that 12 cc's, this has to go over so many centimeters, then it has that measurement, and it will decrease its size and slowly compress to infuse at the right rate.
That's very awesome.
So pretty cool.
Stuff you wish you invented.
It's the most exact way to give medications to the pediatric patient. For even those critical patients on drips, they'll put it in the syringe pump, and that's actually more effective than putting them in the big IV pump. Remember we talked about how on the big IV pump, the fingers go down and go blub, 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 and they give those, it's like almost like getting miniature boluses. Well, for the pediatric patient, if they're on a drip, and I have them on something like a continuous medication flow, if I have that every time it goes down, it has to pause to go back up. So they're getting, for the patient, no big deal for us because we have a lot of volume to absorb, but for the tiny neonate, that one run down to the fingers is a bolus of the medication. And as it resets to go back to the top, to push down again, it's getting bolus and then starve, bolus and starve, bolus and starve when it comes to drips, which can make an unstable patient. So that's why they put it on the neonate patient, because it's a gear set that has a nice continuous flow that's very good for the patient. So there's some important reasons and different patient populations for the reason why we use these medications, or this modes of medication administration. Patient-controlled analgesia. This is a way we can control pain. There's a lot of studies showing that when patients control their own pain management, they use less medication, use less narcotics. So we put them on this pump, and it has a big syringe in it, a big 30cc syringe and a concentration. And you can program it so they have a button. They have a button that you have in their bedside, and it looks like a call light, and they push the button. They push the button when they want a medication. You set out the lock. They can only get a medication dose every so many minutes. So if they push it once and they push it like 30 seconds later and push it 30 seconds later, push it 30 seconds later, then they're only going to get the one dose based on the time limit that you set. But something that the machine keeps track of is every time there's a demand. So if I can know that if I'm not appropriately medicating my patient, you'll see more demands than doses, because they'll be just sitting there pushing a button. Or if they like to be snowed over with narcotics, you'll see a lot of button pushes. And so then you know either you're dealing with a narcotic abuser or you're dealing with someone that's in real pain. And it's actually your patient assessment that tells you that. Because if they're like, oh, it's so bad, it's the worst ever, then you're like, okay, you just like being snowed. But if they're sitting there diaphoretic, heart rate's up, blood pressure's up, and they're hurting and rocking in bed, and they have a bunch of demands, then you know that either, we need to change our settings. The other thing that it does too is not just a one-time dose every time they push the button. There's actual continuous rate that you can program in there too. So they get a tiny low dose that runs continuously to help manage pain. And then you can set the bolus dose from the button at a lower dose, so that way you're using less narcotics and they have better pain management. So commonly used for surgery cases, and then you can wean them off the PCA and put them on oral medications, and they do quite well.
They did that in my daughter's epidural when she was pregnant, when she just had her baby.
She have a PCA button that she could push?
Yeah.
So what they'll do with that is they can, depending
It had
on,
the constant drip,
yeah, you have a constant drip.
and then it had a bolus.
Mhm. So
That was like-
the thing with epidurals is they will, epidurals have, not only do they have a narcotic mixed with it, but they also have a numbing agent. So like Narcan, which is a cousin of lidocaine, and they'll mix in lidocaine with like fentanyl, which is a narcotic. And then you can increase the amount of the narcotic use, so they'll stay nice, alert, and oriented, not get snowed. But that marking on the spinal cord causes the numbness for the epidural, so they don't feel it. So it's a combination. But yeah, they do that.
She got her epidural way too early,
Mhm.
and so it had worn off. And so that was their
Oh.
solution.
So usually with epidural, they can do infusion or they can do bolus dosing. So they'll leave the catheter in place, and they'll usually give you a bolus dose, and then see how you do, because it lasts for so many hours. But if they need to, they can add
They did it that way.
so. Some common components in the IV solutions that we use that will kind of tell you what you have. So if I have D5, that means I have dextrose 5%, right? So D stands for dextrose, W stands for water. So if I have D5W, that's dextrose 5% in water, right? I have saline, so S. So if I have NS, that's normal saline. There's different types of saline, so you have to make sure that you pay attention to that. NaCl is the chemistry, symbols from the periodic table. So sodium chloride. Ringer's lactate and lactated ringers. I guess depending on what country you're in, but some countries will use Ringer's lactate, but here in the US you will always see LR. LR is synonymous with lactated ringers. And that is IV solution that has some extra lactate ions in it that works as a bicarb to help with acidosis. There's some extra things in there that are specific to lactated ringers that make it. So there's a lot of extra electrolytes and components that make it lactated. So here's what a label will look like. Okay, 5% dextrose and 9% sodium chloride, or D5NS.
Yeah.
Okay, because 0.9, remember this? I had a problem with this last semester. 0.9% is normal saline. So if I have half normal saline, because I don't have to give you the percent, I can tell you half normal saline, how much percent is that? 0.45, right? Because 0.9 is normal. What if I have quarter normal saline? 0.9 divided by, times 0.9 times 0.25, or 0.9 divided by 4
Right.
will get you 0.225%.
Right.
Okay? So on some of your homework problems, you might see D5NS as the solution. How many grams of D5 and how many grams of dextrose and how many grams of sodium chloride? Well, you don't know the percent because it said D5NS. But you do know the percent because NS is always 0.9. So you need to make sure you remember that for your math, for your IV solutions, assignments, and exams. Okay? So just remember, if I have half normal saline, then I'm going to have half of 0.9%. If I have quarter normal saline, I'm going to have a quarter of 0.9%. Okay? So you might see some problems that have that, and you will have to know that. Okay? That is something that you need to learn and understand, memorize, and know. So if you look on here, each 100 ml contains this many grams and blah, blah, blah. It has all the ingredients to make this solution, even the additives for preservatives. Okay? So just remember, we'll do the math for this on the board in just a second. Here's a D5, just D5 by itself. And if it's D5 by itself, it doesn't have to say water. It is just known that if I have D5 with no NS of any kind added to it, that means I have D5W. D5 in water. So this would be an example of that. Do you see a D5W anywhere on here? No, but do I see anything else? No, so I know that that's D5W. Here's lactated ringer. So this has 600, each 100 mLs has 600 of sodium chloride, 300 of sodium lactate, 30 milligrams of potassium chloride, 20 milligrams of calcium chloride. Do you see all the different additives we have in there?
Yeah.
Okay, so that's some of the things that make this a lactated ringer solution.
What makes a doctor choose between lactated ringers, saline, or like if they know your electrolytes are down?
Patient condition.
Yeah.
And patient, so I mean like what's not patient condition, like how stable they are, but what they're in there for. So
Right.
a pregnant woman usually 99% of the time will get lactated ringers because of studies showing that that's beneficial for pregnant women. Burn patients will get either 0.9% saline or they'll get lactated ringers, either or. Both are considered what we call isotonic solutions. You guys understand what isotonic means? A lot of the concentrations are pretty similar to that of blood, so it's isotonic. Hypertonic would mean that it has more electrolytes than your blood. Hypotonic would be less than your blood. But lactated ringers is considered an isotonic solution. So if I have an order for an isotonic solution, I can grab either or. But the doctor makes that decision. But patient condition that's causing you to have to hang it is the primary reason we use it. For pediatric patients, we always don't use isotonic solutions. Sometimes we'll use hypotonic solutions based on, because it changes what happens at the cellular level.
Right.
Okay, so if my cell is 0.9% on the inside, and I give it, if I give it a hypotonic solution, what's it going to do to the cell?
Go.
It's going to suck either fluid into it or going to push salt out. So water goes to salt, so it's going to suck water into the cell, which can then pop my cell. It can make my cell die. So that's why we're really careful with our IV solutions, because it changes what happens at the cellular level for the patient. I know it's a really complicated answer to a really simple question,
That's okay.
but it gives you an idea why we do that. So
Thank you.
just remember, for future reference, if I want to give my patient a certain amount of sodium, or they are hypernatremic or have too much sodium, just because it's sodium chloride or sodium lactate, what is the common thing between those two? Sodium, right?
Yeah.
So let's say I have a patient that needs phosphate. I'm going to give them phosphate. Phosphate ion cannot just be given by itself. It has to be attached to another ion. That's just chemistry. That's what you learn in your chemistry class. So if I have a patient that is hyperkalemic or has too much potassium, I can give them sodium phosphate and then give them that dose. If I have a patient that is hypokalemic that needs phosphate, then I can give them potassium phosphate. Does that make sense?
Yes.
So you have to make sure that you look at what you're giving the patient, because more than once I've had, in the hospital setting, primarily we give potassium phosphate to our patients when they need phosphate. Because low potassium is not too, usually when they're critically ill, they have low potassiums anyway. So we give them potassium phosphate when they need phosphate. Unless I have a renal failure patient that needs phosphate. If I have a renal failure patient that has phosphate, that means usually renal failure, they'll usually have a high potassium. Do I want to give them more potassium? No. But when they order, they just order phosphate. They need this many phosphate. So it's my job as a nurse to say, oh, they don't need any more potassium. Hey doc, can I get an order for specific sodium phosphate? And then he'll be like, oh gosh, yeah, thanks. And he'll write the order and change it. So that's our job, to make sure we understand what we're giving, okay? IV blood, okay? IV blood setups, we only prime with saline, and what you have is a filter in there to make sure that I'm not giving my patient any clots. Very important if what I'm giving my patient, that it runs through a filter. So you have your blood. You prime it with the saline first, because you don't want to prime a dry line with blood. That can cause more clotting. So you prime it with saline first, so you have a nice lubed up line, and then you can prime in your blood, okay? Do you guys remember, who here is taking anatomy? So we know that there's the different blood types that are very specific to patients. And not only are blood types specific, but when we cross and type a patient, cross and match a patient, we'll find out their blood type. But before we give them any of this,
You gotta do the back type.
they have to make sure that this specific, like let's say I am A negative, which this blood type is. Before I get this blood, the specific bag, they'll actually take some of my blood and test it with this specific bag. Because I might be A negative, but I also might have some antibodies that have built up in my blood that will make it so I can't get this unit of blood. Does that make sense? So even though I hang the right eye type, I still could have a blood reaction.
And then they'll give you the O negative.
So yeah, you can get O negative, or what they'll do with the blood is they'll do what they call irradiate it. And that kills any antibodies that might be on here, so that way your body can accept it.
Rogam is.
Rogam is for,
Oh, sorry, that's
it's for patients pregnant women who might have different blood types than the baby. So just some cool things. I know this is a lot of information. This is some of the stuff that you'll see. But here's the math, okay? So if I need to figure out mLs per hour, you have the total mLs ordered over the total hours ordered. When you do that math, then you get mLs per hour, right? So if I have 1,000 mLs that needs to run over 10 hours,
Okay.
1,000 mLs over 10 hours, when I divide 1,000 by 10, what does that give me?
100 mLs per hour.
100 mLs per hour, right? And that's all this is saying. That's the quick and easy way. If you know you have a set volume and you know you have a set time, you can do it this way, really quick. If you have to actually do some math based on some medications that might be added, then it's time to do dimensional analysis. But this is just the quick down and dirty if you need to figure it out. This also helps me if, let's say, I have a patient that I'm watching the urinary output. And the urinary output, the doc says, hey, if urinary output gets under 30 mLs per hour, give me a call. Okay? Well, I'm not seeing our ICU. We have a little fancy critical monitor that tells us the exact mLs per hour every hour of that patient's urinary output. So if I don't have that, then I actually have to go in there and measure it every hour. Well, let's say I forget a couple hours. So I go and check my urine set, and I have 90 mLs over 3 hours. So what's my average urinary output?
30 mLs.
That makes sense? 30 mLs, 90 divided by 3. So my average urinary output is 30 mLs per hour. Do I need to call the doc?
Yes.
No, if it's less than.
Less than.
So then I'm like, I don't have to wake him up tonight. Cool. Right?
They don't like to be woke up.
So that's some of the ways we do IV flow rates, or if we're watching urinary output or something like that.
I didn't see this formula that you just put on the board in the book. It's in the next chapter.
Okay, so if I have, let's talk about this. If I have D5W, which by the way, unless it's in drip form, we will never give D5W. Okay, we always give some sort of sodium component or something to that. Okay, but if it's mixed with the medication, it's about the only time you use D5W. But D5W, 250 mLs over 2 hours. How many mLs per hour do I need to set my IV pump?
250 mLs over the next 2 hours.
125 an hour.
125, right? 250 mLs total divided by 2 hours total equals 125 mLs per hour. Okay, and we'll do some of these on the board.
There it is, right there. So he's got to be in 21.
And I'm glad that I missed a week, because now I'm spreading these chapters out. Instead of doing 2 in a day, we're going to do, for the rest of the semester, we're doing 1 chapter a day.
Well,
That way you
this
can
is,
get,
what you're doing right now is in 22.
okay,
The formulas and everything are right there in 22.
you're right. So I will stop here and let's do some math for 20. Let's do some of the ones from the book. Okay, this is where you're gonna have some problems that take you a good chunk of time because they're math intensive, the problems for this chapter. Okay. We did some of these on the board before, but this is a reminder. So let's look at chapter 21, chapter 21. Just a reminder with IV solutions, let's talk about that really quick. What does D5W really mean?
Dextrose,
Dextrose 5%. 5%
was
water.
5% in water. But what does that really mean? What's 5% mean?
5% of dextrose.
5% of dextrose, yeah, we know that.
but of what?
What makes it a
Yeah,
5% solution?
That there's
If
5%
you
of
have-
that in whatever, how many,
There,
That's what a 5% solution means. That in 100 mLs, I have 5 grams. Right? Because what's 5% ultimately? 5 over 100, right? What's 10%? 10 over 100. Right? If you were going to do percents into a fraction. So think about that. If I have a 5% solution, then I'm going to have 5 grams 100 mLs. So we have, what if it's D25, which is a medication, which is what we give neonates when they're
25 grams.
hypoglycemic.
25 grams.
So that would be 25 grams, right? What about 50 grams, which is what a 50% solution, D50, which is what we give patients that are hypoglycemic and having an unconscious. We give them a big bolus of sugar, okay, dextrose.
It's
So what's that mean? What's
half
50?
dextrose and half water.
Yeah, so what does that mean on my math though?
50 grams.
50 grams
grams.
in 100
of
mLs, okay? But remember, a percent solution is only telling you your concentration. That is not an order. So if I have an order for, if I have something that says D50 in water, am I going to give them 100 mLs? No, there's going to be an order associated with it that will say 1 amp, which is 50 mLs, or it will say give 50 mLs of D5 or D50 or something like that. Because that is your actual dose now to this dextrose medication, right? It's no longer just an additive, it's actually considered a medication at that point. So, if I have a neonate, and the order is D25, D25W 50 mLs times 1 stat. So do I have to do much math for that? No. If I have D25, I'll give 50 mLs, right?
If you only have 100 mLs, it's 12.5 grams.
Right. So what do I need to? But if I want to know how many actual grams am I giving my patient? So it's a percent solution. 2 ways to do this. Ratio proportion actually is the easiest, but we'll do dimensional analysis too. 50 mLs, right?
25.
It's 125. Right? Nope.
No, that's 12. 12.5.
Oh, it's not 100, so that is 12.5 grams. So that's the actual amount of sugar I am giving my patient. Okay? That's using ratio and proportion. But like I say, I want you guys to use dimensional analysis.
Yeah.
So if you want to practice in dimensional analysis, that's fine. You're going to find that once you get pretty proficient at this math, you might use ratio and proportion for some things, you might use dimensional analysis for other things, okay? So in my world, I use ratio and proportion for these types of problems, okay? But you can use dimensional analysis, and let me show you how. If you want to stick to one, okay? But use whatever makes sense. Just make sure that if you know if it's this type of problem, you're going to use this type of math, okay? That way you get it right every time. Just be consistent whatever you do. So if I have dimensional analysis, I need to convert this. Think that's because that's what dimensional analysis is. It's actually converting, okay? So I need to convert this from mLs to grams. So I have my beginning dose, 50 mLs, right? We use conversion factors. So what's my conversion factor? It's 25, right? Grams into 100 mLs. So what's going to be on the bottom?
100 mLs. And 25 grams goes on top.
What's my answer going to be now?
50 times 25.
That's using dimensional analysis. I will accept either or on your online work. Just make sure that you show your work. That's all I ask for. So if you just do it like this, 50x 25 over 100 equals 12.5 grams, and you have the right unit label, I will accept it. I don't need big explanations. I don't need a ton of math. I just want to know that, hey, I use dimensional analysis to figure out this problem. Or if you put this on your box, that's fine with me too, because now I know which method did you use? Ratio and proportion, okay? So I know that you cross multiplied and divided, okay? But just make sure that the work you post here coincides with your answer, okay? Because I've been lenient on that with some people, and then I get a bunch of numbers that don't match an answer, meaning they Googled it. They said, hey, how many grams would be in this solution? Google will come up with an answer, okay? But then then they'll have a bunch of numbers of,
Yeah, and then you know it's Google.
and then they'll put an arrow over for the right answer. Does any of that coincide with this? No. So I do check your math, okay? I just check it quickly. I know exactly, so I can know what numbers you used, okay? So don't get tricky on me. All right, so this is something you might see on your problems. So we know that dextrose is D. Well, we have NS here, but I'm asking for NaCl. They're the same thing. What is NS?
Normal saline, 0.9%.
Okay, so now I can do my math. Just remember, this is now two separate problems with twice the points when you get something like this. Dextrose. So I have a 5% solution. I have 750 mLs. So
37.5.
5 times 750 divided by 100 is
37.50.
37.5 grams in my 750 mLs. So that's one. Make sure you label. Now I have normal saline to do. Does that make sense? 0.9 grams, you just put the percent take the percent sign, add a gram to it, and put it over 100. Cross multiply and divide.
6.75
6.75
equals 6.8.
So I'll accept up to the 2 decimal places.
Okay.
Does that make sense? Would you like me to do a dimensional analysis? Do the same thing? Okay.
We do that one.
Let's do a dimensional analysis. Start with what I have. And then I do my conversion factor. What's on the bottom?
And that's,
mLs, 100 mLs, right? What's on top?
5,
5 grams. So what's left units wise? Grams, which is, okay, dextrose. What's on top and what's on bottom? What needs to cancel out? 0.9 grams on top, because I want grams left and I want mLs to cancel. This is dimensional analysis. We're doing conversions. Okay? Okay, so 750 times 0.9 divided by 100. 750 times 5 divided by 100. Okay? There you go. Simple enough, right? Let's do it again. Let's do it again. Pediatric patient. What do I gotta do first?
the dextrose.
Let's do the dextrose first.
250 mLs. And it's gonna be 5 over 100. So that give you 2,500 over 5, which will give you 500.
No.
Oh, I'm sorry.
250 times 5 divided by 100.
Sorry, I did it wrong. 4.5.
Okay, quarter normal saline.
0.225.
How do we know that that's 0.225?
Because your 0.9 normal saline is 0.9.
0.9 divided by 4.
Is that showing up on there? Okay. Right? Cross out my units, leaving me just grams. So 250 times 0.225 divided by 100.
Uh, 0.56.
What's the actual total answer?
0.5625.
If you want to be exact, that's fine. Okay. Because that actually is the exact answer, right? 4 decimal places. It doesn't go any further. It's not a run-on, so that's fine. Okay? That,
So it's added to the baby.
okay?
Yeah.
Does that make sense? Let's see what else.
Do another one like that.
Yes.
to practice.
Let's do it.
Just the fraction, whatever they have.
I ain't scared, let's keep doing them. We got time, we got 30 plus minutes, right?
Yeah.
I have one, I think.
So that's 0.45.
These are a little harder, you could do this one.
Let's do one more of these and then I'll pick one from the book.
Okay, so, what's the first thing? Oh, D10.
Start with 19.
4.1625.
So 925 times 10 divided by 100 would be about 92.5, right?
That's the dextrose.
Uh-huh. What's half an S?
0.45. Uh, 4.1625.
So 925 times 0.45 divided by 100 is, what'd you say?
416.25 divided by 100 is 4.1625.
4.1625 grams of. Okay.
One second. The number 9 in the book says, calculate the non-dextrose and sodium in each of the following IV solutions.
The number 9, what page?
518.
Okay. So this is exactly what we've been doing on the board, so but that one has a little bit different.
Oh, actually, it's
Number
really,
9.
it's super
Is that number
simple.
9?
Yeah.
You don't have to do any math. Dextrose is 5 grams.
Hold on. Let's write it up on the board. 0.5 liters of D5 quarter NS. D5 quarter NS.
And the question is, how many grams of dextrose? And how many grams of NaCl? Sodium chloride.
Okay. So, we do two things here. I know right off the bat that 0.5 is 500 mLs. But if I can't remember that conversion, I can do this. So now I'm in mLs. We're doing dextrose first, so I want mLs to cancel. So 5 grams and 100 mLs. So now my mLs, so my liters canceled, my mLs canceled, leaving me just grams, which would be 0.5 times 1,000 divided by 0.5 times 1,000 times 5 divided by 100.
So 500 times 5 is 2,500, so 2.5.
What is it?
2.5.
2 point, is that right? 2.5, no, 25. 25 grams. 2.5 would be 50 mLs.
Oh, so. And then the NaCl is 1.125.
So let's see here, 0.5 liters times 1,000 mLs over 1 liter, so liter cancel, times my 0.225 grams over, because that's quarter, which is 0.9 MS divided by 4. mLs cancel, leaving me with just grams. So 0.5 times 1,000 times 0.225 divided by 100.
500 divided by...
Right? Okay, quick question. How many milligrams of sodium chloride are there? So what grams are now?
1,125.
Yeah.
Right? So, just in case you see something like that. Okay. That is chapter 20. 21 will fall, that's chapter 21. 22 will be next week where we start doing more with rates and other things like that. Okay. Sound good? Any other questions before I stop this? No?
So if you have like instead of having a fraction of NS, like I'm looking at it on the book, so but it says like 0.33% of NS.
So that'd be 1/3 NS, right?